okay, we can read your T-shirt also. And I think
I've got
I
to put
will
that
first
out there.
say I will first say that welcome to the land of carbohydrates. Welcome to India.
Thank you very much. I think it's the planet of carbohydrates. If you want to get away from carbohydrates, you better book a flight on Elon Musk's flight to Mars because they're everywhere. It's ubiquitous. Um, but first of all, thank you so much. I'm honored to be part of this incredible lineup that you guys have assembled. Thank you very much. One
So,
very, very important point that we need to make a distinction, especially because we're somewhat evangelical about where we are, and yet there's a lot of skeptics. As Anup said, he was told he was going to die if he ate carbohydrates. So one of the key things is that we exist as a species because of carbohydrates. They have sustained us through hardship. They have sustained us through troubled times when we had food scarcity. And in India, you've got this polarization of some folks who are still struggling to survive and don't have adequate food, and then others who live in an era of unprecedented abundance. The issue is not carbohydrates. Carbohydrates do not cause harm. Our relationship with carbohydrates does. And it's such a crucial thing not to demonize carbohydrates as a food source, but when carbohydrates transition across in our relationship with them, that we use them for emotion management rather than for nutritional management. That is where harm begins to happen. So we really have to quantify, and in the ketogenic space, we often demonize carbohydrates. No, 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 no. It's our relationship with them that's the problem.
very nice, very nice. I think that was a very good prelude. And I'll take few minutes in the introduction. I think everyone deserves to know much more about you. And first, I will have a brief introduction about D Life. So I'm Shashi, a metabolic health coach from D Life, India's first and only award-winning low-carb platform. And of course, it was founded in 2014 by Anup Singh, who is from IIT Roorkee, and that was silver medalist and Icons of India awardee. And he also pioneered the low carb movement in India. Anup is known for his groundbreaking 100 grams of carbs per day max protocol made in 2012 to make low carb very, very easy in India, especially for type 2 diabetes management and especially for vegetarians. So in 2020, he launched D-Life Diploma course, the only NSDC partnered diploma course which is recognized and has the world's largest 144 CPD hours. So of course, everyone knows that me and Anup, we co-organized this historic conferences, Metabolic Health Conference 1, 2, and this 3. So Dr. Cywes is a bariatric surgeon. So many of you will be surprised to know that he's actually a bariatric surgeon and a dual board certified specialist in metabolic health, obesity, diabetes, and carbohydrate addiction, currently practicing in Florida, USA. With the expertise of both pediatric and adult metabolic disorders, he has pioneered the carbohydrate insulin model for obesity and diabetes, CIMOD, and has developed a clinical metabolic health program focused on TCR, therapeutic carbohydrate restriction, and behavioral model transformation, which he has just mentioned. So he holds a medical degree from the University of Cape Town, completed his surgical training in Toronto and Michigan, and earned the PhD in liver metabolism and vascular inflammation. He is a global speaker, and we all know that, and on chronic disease, insulin resistance, and carbohydrate addiction, emphasizing substance abuse methodology over traditional diet. He is also founding member of SMHP, and he continues to lead in the metabolic and obesity care. He recently co-authored several chapters in ketogenic textbook, The Science of TCR. He has also earned a Center of Excellence designation from Surgical Review Corporation. So once again, Dr. Cywes, welcome to India.
Thank you very much. I appreciate that introduction. And just to quantify that introduction, yes, my background is in surgery, but there are other people whose background is in endocrinology, whose background is in ophthalmology, whose background is in cardiology. And one of the key things, no matter what specialty you're involved, from podiatry to hair replacement, if you don't understand the role of insulin resistance and the modern human diet that most people are into, number one, if you don't understand it, you should not be giving nutritional advice. And number two, it behooves you for any specialty to understand the nature of our relationship with food and a transformation in that relationship as it impacts whatever your specialty is. So while I'm a bariatric surgeon, I deal with obesity, I deal with a number of weight health issues. I've made it my point to understand why my patients get into the trouble they do and to give them appropriate advice, not just do a Mediterranean diet or eat less Coke or do more and eat less. That nonsense, you can go onto the street and ask anybody, and they'll give you the same advice that most doctors give you about nutrition. And it's false, and it's led by false policy and a false narrative that we have been trapped into. And I'm hoping over the next 4 years, certainly here in the US, we'll have a leadership change that alters the entirety of food policy.
So you have been defining carbohydrate addiction as a substance abuse. Usually we hear this for drugs, and it's a substance abuse, emotional management problem rather than a dietary issue, and which leads to probably obesity, type 2 diabetes, cardiovascular, which are just the expression of this addiction to carbohydrate. Can you explain a little more, because people will like to know more about this?
Yeah, I think the key thing about anything that we call a drug, and really I'm going to expand it a little bit more, any behavior or any substance that gives massive upfront instant gratification, instant or endorphin relief, instant relief from emotional tension, whether that's anxiety, stress, depression, anger, fear, frustration, exhaustion, boredom, pleasure. Collectively, I call that emotional tension. And all human beings at a very, very early age, probably in utero, begin to develop strategies to activate the endorphin system that gives us relief from emotional tension so that we can function. And in the first few years of our lives, we all discover certain aspects of that. And it may be a behavior, gambling, sex, pornography, which is a process addiction. It may be a substance, and the traditional ones are the opioids, the alcohol, nicotine, crystal meth, crack cocaine. But all of them, by definition, have a massive, powerful endorphin activating role. They all can be done to excess. And when you do them in a chronic, excessive way, they have to cause harm to be defined as an addiction. The word addiction is often used by people where they don't quite understand that reality. The word addiction has to be predicated by significant harm. If there isn't harm, you may have an abusive relationship with that substance, but there's no harm. So, for example, if I get drunk one night, I may have abused alcohol. If I have a DUI, I may have abused alcohol, but I may not be an alcoholic. But if I've had 5 DUIs and I've got liver disease, I'm an alcoholic, no matter whether I believe it or not. And carbohydrates, sugar, and starch. And the key thing is this: it doesn't matter. We quantify the quality and the value of food by how it enters our mouth. But remember, our mouth is outside our body. The transition happens when that substance crosses the gut barrier into the bloodstream and goes to the liver. You can drink wine, beer, and whiskey. It's alcohol that enters the system. So an apple and a donut carry the same amount of sugar and starch, and it's exactly the same. Yet we quantify one as healthy, the other as unhealthy. But that's a societal issue. However, carbohydrates, when they hit the brain in a significant rush, cause exactly the same endorphin chemical response as all of those other more classic drugs. All because we human beings haven't yet assigned or recognized that as a problem, it doesn't mean it isn't. And all you have to do as a practitioner is listen to your patients and watch that relationship. And you'll very, very quickly understand that their entire behavior, because addiction is not something we do. Addiction defines who we are. So addiction is, by definition, if someone doesn't drink alcohol, you're an alcoholic. You're a smoker. You're a crackhead. And in my case, I was a fat person. But that is, a carbohydrate addiction is one of the few addictions where we define it by the outcome. So if you've gained 5 or 10 pounds, you may have had a bad Christmas or whatever it is. But when you're more than 25, 30 kilos, 50, 60 pounds overweight, when you have type 2 diabetes, that is the quantifiable harm. To get to that point, you have to indulge in this addiction, indulge in your relationship with carbohydrates to such an extent that you are defined by the relationship. And that's addiction.
So, Dr. Rob, that was, you made a very interesting point. And, I always keep saying that whether it is an apple or a donut, as long as, you are taking in same amount of net carbs, which is going to turn into same amount of glucose, this theory of complex carbs, simplex carbs is all nonsense. because body will need same amount of insulin to produce, to process same amount of glucose. Now, coming back to question, how does this addiction model explain why people, struggle to reduce carbs or not exactly give up, reduce carbs, and despite knowing the health risks?
So just to answer, the best way to know what you're eating does with you is to wear a CGM, okay? This tells you immediately, because if you eat carbohydrates, the apple or the donut, your blood sugar spikes. So it's a very, very useful instant feedback. The scale is a very poor instant feedback, but the CGMs, which are ubiquitously available, are an incredibly effective way to know what you're eating does to your inside your body. But to come back to the question, I think one of the issues with human beings is there are really two forms of emotion management. There's instant gratification, and there's what we call effort-based. So, for example, if I have a really rough day and I have a fight with someone, and I come home and I eat a tub of ice cream, I have instant gratification, but on the back end, there's harm. My blood sugars go up, it's affecting my heart, it's affecting my weight, my diabetes goes up. If, on the other hand, I come home and I leash up my dog and we go for a walk, that walk requires effort and time up front. I don't get the instant gratification. But as I'm walking, my emotional tension subsides. I'm able to connect with and process that issue. And by the time I come back from the walk, I'm emotionally relaxed. I've got a game plan for dealing with the issue, and I'm feeling pretty good about myself. I do not need to defend it. So the issue with carbohydrate addiction is that it occurs in people, any addiction occurs in people with a comprehensive deficiency of effort-based emotional off-ramps. So the young child has a lot of emotional tension built up. They don't have an effective way of dispelling that, of getting rid of it. They bump into a drug. And the commonest, most ubiquitously available drug, as soon as kids are weaned off the breast, if they're breastfed, is sugar and starch. We take them from a pure carnivore meal, and every child, whether you're Hindu, whether you're Christian, Jewish, doesn't matter, is raised on a 100% carbohydrate diet if they're breastfed. Just put that into your mentality, because breast milk is. But then suddenly we're giving them a bunch of carbohydrates, cereals, goldfish. We're giving them a variety of carbohydrates as soon as they come off that carnivore diet. And for some people, it's okay. They can handle that because they've got a diversity of other options. But for some people, some young children who do not have other off-ramps, they develop that relationship very quickly. And they're going to the fridge, grabbing something. Whenever the child is noisy, the mom's giving them something to eat. And it's not steak and broccoli. It's usually some sort of sugar or starch. So we entrench that behavior. And when you've got that as an opportunity, if you've got access to carbohydrates, why do you need to develop other things? Why do you need other emotional off-ramps? So the vulnerability to addictive behavior is imprinted and occurs from our parents within the first 2 to 3 years of life. And then it's a question of which drugs we bump into during our early lifetime as to which addiction we follow. A lot of kids have all this emotional tension built up. Now this is where India is beautiful as opposed to the US, because in the US, here in Florida, in middle school, these kids are discovering vaping, electronic cigarettes. India banned electronic cigarettes. I mean, it's just such a smart policy move. But 60% of children in Florida at high school vape on a regular basis. They're using marijuana and they're using nicotine as their emotional off-ramp together with the carbohydrates. So it occurs very, very early on. And addiction is a default to the lack of diversity in terms of emotion management strategies.
Now, I want to ask a very, very key question. I think it's going to be very, very relevant to India. What are the 3 core aspects that require transformation to overcome carb addiction?
Well, when you analyze, and I think this is an important concept, just as a preemptive part, you're going to have 3 people on this wonderful conference. You're going to have people who are speaking from a personal perspective. They've got a personal story. Like the last person that was on, beautiful personal story, but it's an N of 1. Then you're going to have people that are researchers, that are biohackers, that are going to talk about research. And then you're going to have a group of practicing physicians and practitioners who are in the trenches, who are observing other people. And then it's not about me, it's about what I'm observing in our patient population. And one of the problems with healthcare, it has become a generic algorithm that no matter who walks through the door, we've got an algorithm of best practices. You're going to get exactly the same treatment. What I have to do when a patient walks into my office is create an individual relationship, understand who they are and where they are, and then manage them appropriately for their needs, not the way I want them to be, but the way meet them where they are and help them to transform slowly. Having said that, there are three dominant aspects to carbohydrate addiction, and it's not food addiction. Nobody's addicted to fluids. We're addicted to alcohol, okay? And when you're dealing with alcoholism, nobody tells an alcoholic what they must drink, but everybody loves to tell fat people what they must eat. No, don't eat the carbohydrates, don't eat the, and that's why you can manage this, whether you're vegetarian or whether you're carnivore, by getting rid of the carbohydrates. So the first thing is the drug itself is carbohydrates. But when you smoke, it's not just the nicotine. There's a whole relationship, there's a whole ritual that is involved in the emotion management. Every smoker has the same type of cigarette that they smoke. They have a ritual by which they smoke. And the rituals when it comes to carbohydrates, number one, it's the drug itself, sugar and starch. And everybody has their poison. It might be more salty, it might be more sugary, might be more starchy, might be more simple. But the second one is this. A snack. A snack is always, always, always an emotional event. It is never a nutritional event. Okay? You see me sipping on my coffee. This has nothing to do with hydration. This has to do with a little mind cleansing moment that gives me a little moment of reprieve so that I can focus. And the human brain needs that break every 15 to 20 minutes, particularly when it's focused. And the carb addict is having a little snack of some form of caloric load. So a snack is always an emotional event. My coffee contains nothing. It's a bridge across that need for something emotional without causing me caloric harm. It's gum instead of a cigarette. And then the third component is binge eating disorder. And our society has created and indoctrinated us with binge eating. Most of the time with our children, finish your plate. We very, very early on in a child's life, a normal healthy person, any animal, a normal healthy person has a very tight feedback system between your brain and your belly. Your brain says, okay, I need food. You start to eat, and the chemicals and the hormones in your belly go back to your brain and say, hey, you've had enough. And there are certain hormones that create satiety, one of those being GLP-1, which everybody knows is Ozempic. But when we determine preemptively how much we think we need to eat, and the brain tells the belly, eat this, this is how much you're going to get, we very rapidly override and destroy that natural feedback pathway. We've tried to experiment with ghrelin and leptin, which are some of the feedback hormones, but we've been indoctrinated by portion size to override, and most of us will eat very rapidly, and we eat what's in front of us. So part of the therapy there is to put less on your plate. Let's face it, if you don't eat enough, you don't have to grab your bow and arrow and go outside and shoot something. You can walk 5 paces to the kitchen and get more food. So if you start with a smaller amount, and it's amazing preemptively when we're dealing with addiction, how intense we need that massive amount of food. But if you put less in front of you and you eat less, it's very rare that you go back for more. So I hate this word, but we're doing caloric reduction intentionally because our belly is being triggered to go back to the brain to say you've had enough. At the same time, we've been conditioned that if you put too much in front of you, you'll override that and finish what's ever in front of you. So those are the 3 concepts that we really have to work with. Removal of carbohydrates, and then I really don't care about what you do eat, just like the alcoholic. There's a variety of different things that are cultural, religious, and palate, as long as you're getting adequate nutrition in. But it's not about what you are eating, it's about what you're not eating. And then working with snacks. But one final thing I'll say to you, and I know I speak a lot, but addiction is never about quitting. The worst thing you can do is quit. And the reason for that is because every addiction serves a very powerful purpose. My carbohydrates have a wonderful, very effective emotion management role in my life, but they create a lot of harm. So when you get rid of them, you are removing the harm, but you're also removing the benefit, and you're leaving a massive void in your life in terms of effective emotion management strategies. So the operative word in addiction is not quitting, it's replacement. If you think about Alcoholics Anonymous, AA does not get the alcoholic to quit drinking. That's a very lonely personal thing. And quitting carbohydrates is a very lonely, very difficult, incredibly difficult thing to do. And only we can do that. But rebuilding ourselves, reformatting ourselves from a more diverse, more effort-based emotion management system should take the rest of your life. But if you don't replace, you're either going to relapse back, and a lot of people will say, oh, it was the holidays, or oh, these stressful events happened, to justify going back. Or alternatively, you find another drug. So you go from smoking to eating carbohydrates. That's called a drug transfer. So remember that it's always about removal and replacement. And with carbohydrates, you want to remove carbohydrates and replace them with other forms of food that are culturally and religiously acceptable to you, that don't include carbohydrates. But also you want to develop an effort-based emotion management system. And I use the algorithm CHESS: creative arts, human connection, physical activity or exercise, spirituality and meditation, and healthy sleep and healthy sexuality. And that is the most robust, diverse form of healthy, effort-based emotion management systems that you can replace addiction with.
Dr. Rob, I think in hindsight, as you said, don't remove carbohydrate. It's not about addiction, but it is about limiting, I would say. So in hindsight, I think the 100 grams carbohydrate limit that we, set on our protocol, do you think it is perfectly fine?
I don't think so. And I think as an entry point, it's absolutely fine. The worst thing you can do is go from your standard high carbohydrate diet to nothing. It's a slow, steady transition. But here's the transitional thinking. And diets are predicated by control and deprivation. Control, I can only have 100 grams of carbohydrates. And the deprivation part is I'm not allowed to have this, I'm not allowed to have this. Addiction is dominated, an effective addiction transition is dominated by the word empowerment. A vegan doesn't feel deprived of steak. That's disgusting. How can you kill Bambi? They're arrogant about the fact that they don't eat that. A Muslim is not deprived of pork or bacon. There's a level of arrogant distaste for it. The Hindu is not deprived of eating cow or meat. It's just part of our cultural identity. So when you create a diet, first and foremost, addiction management will always fail when it's something that you do, because addiction defines who we are. And therefore, this has to be a transition in habits, relationships, and routines that are foundational to who we are as a human being. Of course, you want to start with changing what you're eating. But as you go through this further and further, you want to define, why did I do that in the first place? Because as long as you've got those 100 grams of carbohydrates, those act as a reward. No alcoholic drinks 2 beers a day. No heroin addict just shoots up a little bit on a Tuesday morning. I think as a starting point, absolutely, you've got to go through that transition. The first part is the ownership. Yes, I have this problem and I'm slowly going to manage it. But I think stopping at 100, getting to 100 is essential, but stopping at 100 stops you from progression. And addiction, there is no endpoint to addiction management. It's a set of milestones. And as soon as you reach a certain milestone, I'm only at 100, I'm eating all of this stuff. What's next? I've lost 100 pounds. Yeah, go ahead.
Let me correct myself.
Yes.
It is 100 grams per day max.
Right. And I think the way that I would describe that is I agree with you at 100 or 50 or whatever that set is. However, those are incidentals. So the way we work in addiction, the way I work my own program, the addiction program, is all vegetables are free. I don't care if there is some carbohydrate in carrots or peas or Brussels sprouts, because I've never met somebody who's a carb addict who rushed home to pig out on Brussels sprouts. But the potatoes, the rice, the grain products, both from a health perspective, the grain products are the most autoimmune triggering and inflammatory triggering products, not the carbohydrates, but the proteins and the grains. Most of us experience irritable bowel or a form of celiac irritation. A lot of us do. Hashimoto's, 82% of my female patients come in with Hashimoto's, primarily triggered by grain proteins. So you've got to look at where the boundaries are. But I think in addiction management, the boundaries are binary. So if you count vegetable carbohydrates, I don't have a problem with that because I've never met somebody who rushed home and pigged out on them. So we don't quantify it by necessarily the exact amount, but we quantify it by the relationship. And obviously, if you do have that problem, then you want to change the relationship with that particular food product. And you know what's also interesting, and you'll hear a lot of the carnivores come on here. I manage several thousand pure carnivores. And while human beings do very well on a carnivore diet, over time, they become so fat adapted that they are no longer triggering the release of insulin. And they become what's called insulin suppressed. And the way we correct insulin suppression is actually to reintroduce a little bit of carbohydrate. And Professor Tim Noakes just published a beautiful paper on athletes, on endurance athletes, where about every half hour, the ideal suggestion is about 10 to 15 grams of carbohydrates to support you. So we've got a lot still to learn about the role of carbohydrates in our lives, and it's not complete abstinence, but it's management of the relationship, as I said at the beginning, that is more important than the absolute number.
Now,
Are there
the pertinent question for India is we are deeply high carb and grain based diet, and this is all cultural thing. So how do we think people can navigate and manage the carb addiction?
I think that is a very, very important consideration. I alluded to this a little bit ago, is that we all make choices. We make choices for our children and we make choices for ourselves based on cultural and religious aspects of our lives. And we don't even give that a forethought. A religious Muslim is just not going to, a religious Muslim, a religious Jew, just not going to eat pork. It's not that they don't eat pork. It just doesn't exist in their lives. Okay. A lot of people choose not to drink coffee. My Mormon patients don't drink coffee. They don't drink alcohol. We all make those choices to not do something. We make a choice not to smoke. So ultimately, this comes down not to culture or to religion. We have to take those into account. But it comes down to who we are as human beings and what matters to us. The one thing I can tell you, again, I've got to be cautious in India because of reincarnation, but we're all going to die. And that is one hard endpoint. It's the only endpoint that I can guarantee everybody. How we get there is our choice. And we can choose to, if we've got cardiovascular disease, if we've got diabetes, if we have obesity, we can choose to say, look, I don't like these diseases and I'm willing to give up my carbohydrates. Or you may say, you know what, I'm a religious Hindu, but you know what, I want to eat meat. I'm a religious Muslim, I want to eat pork. Those are choices that each person makes. So I cannot tell my patients don't eat carbohydrates. However, one of the problems that we have in healthcare is the difference between compliance and consent. And healthcare has become all about compliance. You're going to have a heart attack, you must take a statin. And between fear and trust, the patient is fearful they've just had a heart attack and they trust their doctor, but they don't investigate the risks, benefits, and alternatives to that drug and they take a statin. Healthcare should be about two things. It should be about consent, and consent has several stages where the person is free to make a choice and they should be given the risks, the benefits, and all the alternatives to that decision. And healthcare should always, always be about shared decision-making. So I cannot tell you must do something as a physician. I would say, look, this is my opinion, and here's the facts, pro and con, and you decide. And the same is true with carbohydrates. Ownership of carbohydrate addiction, ownership of any addiction, is one of the most difficult things we do. The last person to know that they have that they're an alcoholic is the alcoholic themselves. So as a physician, I use those hard things. If your A1C is above 6.5, I don't care if you agree or disagree with me. you have an addiction to carbohydrates, because by the time your A1C gets that high, this is a relationship that you no longer have control over. And I know that comes down to the 100 grams is the control side. By the time you're more than 50 pounds or 25, 30 kilos overweight, this is no longer something you have control over. This is an addiction. Then you have to decide for yourself, that's the harm. I now have diabetes. How much do I care? Versus my relationship with carbohydrates. But that is a decision that each individual has to make. And what Anup is doing is more giving information to a population to say, hey, begin to work on reduction, which I love. That works at a population level. When I deal with individual patients, we have to set a higher standard if that patient chooses to have that higher standard. If they choose not to, there's very little that we can help them with. And everybody relapses. Only those perfect people on the internet are the people that never ever screw up. I screw up, everybody screws up. We have to help them to manage how do we get back on track. Because every one of my patients is an expert at failing diets. And part of the addiction methodology is it's stepwise. It's not all in a rush. It's stepwise, it's empowering, and we can slowly make new milestones. So you can be successful at milestones. You don't necessarily have to be successful at everything.
Yeah, Dr. Rob, you said 6.5, you consider it as, the break point from where you can decide whether the addiction has to go or it is perfectly fine. For your knowledge, we keep that number as 5.6 because for
I
us,
agree. I agree completely. Yeah.
yeah, because for us, diabetes is much like pregnancy, a binary state, either yes or a no, right?
You know what,
Not,
Anup, you're 100% correct. However, the healthcare tradition is 6.5 defines
yeah, that I
diabetes.
understand.
Now,
That I understand.
a normal blood sugar, a normal A1C is 5.2 or lower. Why? Because at an A1C of 5.2, your average blood sugar is non-contributory to cardiovascular risk.
Yes.
But here's also a very important point that many people don't understand, and as a physician, I understand this. There is a genetic bell curve in terms of disease expression, okay? So, and this is very important in India. In my practice, some people like myself walk past a donut and we immediately gain 5 pounds, but my blood sugar is always very, very level because genetically I can produce a huge amount of insulin. So under the influence of that insulin, no matter how resistant my cells are to insulin, I can produce more insulin to keep shoving that sugar into my cells. I clear the sugar from my bloodstream and I gain weight. And in my fat cells in my liver, I turn that sugar into fat. Now, the diseases that someone like me, I call that an obesogenic genetic pattern. And I can measure insulin, fasting insulin, I can see those levels very, very high. My highest fasting insulin was 87, okay? Normal fasting insulin is about 3 to 4, below 6. So the diseases we get, people like me, and there's a subset of Indian patients, of Indian people who are obesogenic, but the minority, just that's the genetics. But the diseases we don't get cardiovascular disease, we don't get stroke disease unless we cross over. And I'll talk about that in a second, but we get Alzheimer's. We've got a much higher risk of cancer because insulin is a cancer surveillance hormone. We have autoimmune disease. We have weight-bearing joint disease, lower back, hip, knee, ankle disease because of the weight. We get polycystic ovarian syndrome in females, and we get low testosterone in males. Those are the diseases of hyperinsulinemia and obesity. On the flip side, you get people who genetically cannot produce a very high amount of insulin. So they produce a moderate amount of insulin, but pretty quickly the insulin resistance, the blockage of the receptors, is greater than the amount of insulin they can produce. So they all gain some weight. So there's a degree of weight gain, but very rapidly they cannot clear that sugar. So those same people eat the same donut and they don't gain weight, but their blood sugar rises and stays high because they now require the liver to clear it. The liver doesn't need insulin. So that's where their triglycerides go up and the liver clears it. Those are the people that are diabesogenic. And their problems primarily come, obviously it's a bell curve, but their problems primarily come from elevated sugar, which affects the blood vessels. So your cardiovascular risk is high. And it also affects the interstitial space, the space between the blood vessels and the cells themselves. What lives there? Your ligaments, your tendons, your joint capsules, and your nerves. So you're getting neuropathy. You can get ophthalmic neuropathy, you get retinopathy, you get cardiac neuropathy, you get both the plumbing, which is atherosclerosis, and you get the arrhythmias. You get peripheral neuropathy, you get intestinal neuropathy, so you get intestinal problems like gastroparesis, you get erectile dysfunction. So those are the spectrum of diseases, one predicated by hyperglycemia, high levels of sugar in the bloodstream, and one predicated by high levels of, super high levels of insulin. And what's interesting in my diabetics, the first treatment of my diabetics is actually to raise their insulin. Because while they're producing a lot of insulin, this is where I disagree with some of Jason Fung's work, the full suitcase model, is in those patients, we first have to overcome insulin resistance. So we raise insulin levels to make the cell more receptive to sugar. And then as the cell becomes used to sugar, the expression of those receptors and the phosphorylation of the receptors goes down, and they require less and less insulin over time, so we can then withdraw medication. But the first step is to clear the sugar from the blood vascular space. And a lot of physicians don't understand that, but if you work in the space, you can identify the individual patient that is diabesogenic versus the one that's obesogenic, and we have to work with them slightly differently. So the genetic predisposition is a very, very important component. And the Southeast Asian population tends to be more diabesogenic. The Southern Asian population, the Samoans, tend to be very large and more diabesogenic, more obesogenic than diabesogenic, but obviously everybody can cross over at some point.
What are the biggest roadblocks, when it comes to trying to give up this carb addiction, as you say?
The biggest, most obvious one is ownership. And it's ownership at a societal level, because we still think of carbohydrate addiction in terms of food and nutrition rather than drug and addiction. Okay. While alcohol falls in the hydration category or in the fluid category, nobody would think of alcohol as something we drink for hydration. But we think of carbohydrates as something that we still eat for nutrition. So there's a societal level that has to separate the two. And whether it's processed or natural carbohydrates, nobody or very, very few people become diabetic or obese on so-called natural carbohydrates. But once you are, the naturally occurring carbohydrates are as evil as the other. And that's an important concept. So you'll say, oh, you can eat the apples. Yeah, you can eat the apples if you don't ever eat the processed carbohydrates, but the addiction comes from the processed carbohydrates. So the first one is a policy level, but secondly, at a personal level. You get somebody coming in, they weigh 200 kilos, or somebody comes in, they have profound diabetes, we're removing their foot, and they don't understand, they cannot correlate that relationship with carbohydrates. So we have to help them to understand that personal relationship. Then the fear, the absolute fear of not having your best friend. Ask any smoker, the greatest thing is the fear. There is an enormous fear of, what am I going to do? Because all I have is sugar and starch. I got nothing else. You look in a carbohydrate addict's emotion management toolkit, it's carbs and cobwebs. And if you remove the carbohydrates, suddenly, what am I going to do? That's why we remove and replace progressively. So there's that absolute fear. And then there is a physiologic dependency. If you suddenly quit eating carbohydrates, you're producing massive amounts of insulin. Your blood sugars are going to drop. You're going to have all kinds of physiologic harm, just like when you quit drinking alcohol, you go through the shakes, you go through withdrawal. So if you do this more progressively, once you understand it, that's fine. But the ownership part is the first thing. And then the second big issue is managing relapses. And that is where we have a binary approach, so that if you make a mistake, we have to recognize that it was a mistake. You can't go back and pay it back, but we also want to objectify the mistake. If you personalize it, oh, it was my birthday, I just had a little bit. We are so good at rationalizing. Every addict is so good at minimizing, trivializing, and rationalizing our addiction. If you objectify it, you can own it. Okay, I made this mistake. I'm not going to beat myself up, but the next time I'm in the same situation, here's how I'm going to do it differently. And it's ownership. You analyze the reason why it happened, and you make a correction for the future. And addiction management is all about change over time. It isn't change one time like a diet. It's a continuous transformation, including the day you die. Every morning you wake up, what more can I do? That's what we're focused on.
Thank you, doctor. I mean, you gave a lot of insights to us on this carb addiction model, and I think we still have 3 minutes left. Dr. Joanne is here. One last question. We are very curious to know. You are a bariatric surgeon. Still, you keep recommending therapeutic carbohydrate restriction. How useful is bariatric surgery in which population, and why do you still keep promoting therapeutic carbohydrate reduction as a bariatric surgeon?
Well, I think first of all, bariatric surgery treats obesity. It doesn't treat carbohydrate addiction. Just like metformin, insulin, whatever it is, it treats the diabetes, it treats the blood sugar, it doesn't treat what caused it. So every physician out there, no matter what specialty you're in, has a therapeutic element to deal with an endpoint disease. But if you don't simultaneously treat insulin resistance, which is the gateway to all of these problems, you're not doing service to your patients. So the beauty for me, and again, I'll argue with anybody about this because I'm in clinical practice, my surgical need has diminished dramatically because of one drug, the most important drug in my lifetime that has come along for the treatment of insulin resistance, because it specifically treats insulin resistance, are the GLP-1 agonists. And whether you have kidney failure, whether you have diabetes, whether you have Alzheimer's, whether you have cardiovascular disease, whether you have obesity, whether you have diabetes, whether you have PCOS, infertility, the GLP-1s are incredibly effective drugs for the treatment of insulin resistance. But the problem is that most people are backdooring into the GLP-1s. And because they can't get hold of them, they're dosing up at home, they're using them, they're outsourcing to the GLP-1. Same thing with bariatric surgery. People that have bariatric surgery lose weight. People that go on GLP-1s lose weight. Wonderful, kumbaya. But none of them are addressing why the problem happened in the first place. And if you look at the obesity surgery, you look at diets, you look at obesity surgery, you look at the GLP-1 literature, everybody, the majority of people, 96% of patients in the Step 4 Ozempic trial regained all or most of their weight back within 48 weeks of stopping, because they didn't change the relationship, the behavior that caused the problem. So I can do bariatric surgery on one day and get you to lose weight. But my relationship with you as a patient over a protracted period of time is not designed to get you to lose weight. It's designed to slowly, progressively help you to change why you gained that weight in the first place. So the majority of my patients are non-surgical patients. About 1% of my patients right now are surgical. The majority of my patients have had a heart attack. They have diabetes. They want to get pregnant. They have all the other aspects of this. And because I don't consider myself to be a bariatric surgeon, I don't consider myself, TCR is just something, therapeutic carbohydrate reduction, something we use. I am the beginning of a brand of a new specialty called a metabolic health practitioner. And metabolic health is about carbohydrate addiction and understanding insulin resistance. And the SMHP, which I want to promote here, it's an international organization, Society of Metabolic Health Practitioners, was created and built for people like myself who want a new specialty. Tim Noakes created sports medicine as a specialty, and I think the SMHP, so I want to minimize my bariatric surgery. It's just one of the tools I use, just like a diabetic doctor uses metformin or insulin. What we have to become is metabolic health specialists if we want to change policy, if we want to change the influence that we have over our food, and if we want to treat our patients correctly.
One quick rapid fire before we wind off. From all your talks, can I conclude that carb is for entertainment, protein and fat is for nutrition?
I love that. Yes. And don't forget the micronutrients. You're exactly correct. Carbohydrates are like a glass of wine. They're enjoyable, but they serve no nutritional purpose. And if you have a broken relationship with them, then you have to choose whether or not you're going to continue that relationship.
Thank you.
Thank you. Thank you. We'll have a bigger session with you later on someday,
Yes.
because you are an interesting person and we have not dug out even 20% of what you want to say and what you know. Thank you, and we'll get back to you, doctor. Thank you.
Thank you so much. I really appreciate it. Bye-bye.